So my name is Cynthia Sneddon, and on behalf of the Education Work Group at the University of Colorado Cancer Center, I want to welcome Dr. Pollyea to our Lunch and Learn event today. Dr. Pollyea received his medical degree from the University of Chicago, Pritzker School of Medicine. He completed an internal medicine residency at the University of Chicago Hospital, and then served as chief medical resident at Cook County Hospital in Chicago. He completed a medical oncology and hematology fellowship at Stanford University, and he is now an associate professor of medicine at the University of Colorado, where he directs the clinical leukemia program and serves as the Robert Allen, MD, Chair of Hematology Research. Dr. Pollyea's work focuses on improving our understanding of the nature of leukemia stem cells and developing drugs that target this population to potentially allow for curative therapies. Dr. Pollyea has served as the principal investigator for multiple early phase clinical trials and has received funding for his research from the American Society of Hematology, the American Society of Clinical Oncology, and the Leukemia and Lymphoma Society. He is currently vice chair of the NCCN guidelines on acute myeloid leukemia. So we are looking forward to hearing from you today, Dr. Pollyea, and welcome.
Thank you so much, Cynthia. Should I just go ahead and share my screen?
Yes, thank you.
Well, thanks, Cynthia. That was very, very nice, and really honored to be invited to speak to you, to this group here today. Whenever there's a lunch and learn without the lunch being provided, you know that the people who are here are the real deal, and so I'm very happy to speak to such interested and motivated people over your lunch hour. I love telling this story. I jump at any chance to tell it. This is it's just it's been such an amazing experience. It has everything to do with this place, University of Colorado. We have so much pride in this regimen because all of us here have done so much to develop it, and to watch it over the last couple of years sort of get unleashed into the world, and for the entire world to see what we had become so familiar with for over the last several years has also been an amazing experience. And you know, I'm now in this really incredible position where I can talk to colleagues literally all over the world any given week about their experience with this regimen, to see it replicated in so many different places and so many different settings is just testament to how well this works and what great work that everyone here did to develop it. So anyway, the title is Developing Venetoclax in AML. And there we go. Here's the agenda. We'll kind of move through everything. So I won't call out exactly each of these topics. And I'd love if there's time at the end for some questions or just discussion. Also, I mean, we can keep this quite informal, so feel free to just unmute yourself. I'm not looking at the chat box, but unmute yourself and, you know, go ahead and ask a question or clarification as we go. I'm totally fine with that. So I think, you know, the story kind of begins in the 1980s with this seminal paper from Nature, from Science. And this was the first time that anyone showed that this gene called BCL2 could be relevant. And so the way it was discovered was in lymphomas, there are these translocations between chromosome 14 and 18 that disrupted this gene that they later called BCL2. And they noticed that this could result in cancer in a variety of different settings and models, and obviously in the human patients with these lymphomas. And but surprisingly, up to this time, the only way people kind of identified cancers being possible were from genes or chromosomal abnormalities that caused overproduction of cell growth. That's sort of the mechanism that was thought for cancer. this was not an abnormality that caused that. Instead, this caused cancer by preventing normal cell death. And this opened up this whole field of cancer research around things now called tumor suppressor genes, things that are actively working against the development of cancer. And when they get silenced, a cancer can kind of come into the void. So this is all kind of the bedrock of this field. You know, this is the current understanding. It's very complicated, this dance that our cells do to decide if they should live or die. In a homeostasis situation, like a cell that is sort of in status quo, if this is the mitochondria here and all these, and these are different proteins, you have all these proteins in the body that are responsible for regulating this dance between death and survival. And so in homeostasis, you have anti-apoptotic proteins, or proteins that are there to prevent the cell from dying. And that's sort of the steady state, and they're here and they're bound up in the mitochondria. The pro-apoptotic proteins are not active in this situation. But if you want a cell to die, then you have to activate these pro-apoptotic proteins. And so into the breach come these mediator proteins called BH3 proteins. And they basically bind up the anti-apoptotic proteins, prevent them from binding in the mitochondria, and then that allows the pro-apoptotic proteins to rush in and cause all the things that need to happen for the cell to die. Alternatively, if you want a cell to live, then you need to have the pro-apoptotic, the anti-apoptotic proteins that are displacing all of these pro-apoptotic proteins. So they don't allow these pro-apoptotic proteins to bind and cause cell death. So that is, you have to remember, you're talking to a clinician here. So that is my best explanation and understanding of this very, very complicated process. But this is a process that is, for obvious reasons, or maybe not, I'll explain, very interesting for cancer as a therapeutic direction. So we know that, let's talk about lymphomas. BCL2, the anti-apoptotic protein, is nearly universally overexpressed in lymphoid malignancies. So you can imagine that cancer cells don't die properly. We know that. And if they are overexpressing a signal that's allowing them to continue to survive, logically, and this is what came out soon after that 1985 Science paper, logically you'd think, well, let's target that thing and let's let the cell die a natural death, the cancer cell. And so that has been the strategy for decades around targeting BCL2. And that's worked really well in some settings and is now moved into AML. So what we had to deal with in the past were very non-specific BCL2 inhibitors. And I remember when I was a fellow in the lymphoma clinic, we had a clinical trial of a BCL2 inhibitor that also targeted other elements of this apoptotic pathway and caused things like really bad thrombocytopenia. And so the attempts to target this in the past have not been successful until Venetoclax. So looking at this picture here, basically these are the anti-apoptotic proteins here, or some of them. And you can see that they act in equilibrium with those BH3 proteins whose job it is to sort of mediate this decision whether cells should die or not. And in the past, the drugs we've had have been analogs of these different BH3 proteins. We actually call this whole class of drugs BH3 mimetics. And you can see like there was a drug called Obataclax, but it was basically, it inhibited all of these. There was this one, then they got better and better until Venetoclax. So Venetoclax is also known as ABT199. It's the only pure BCL2 inhibitor. And you can see even in the body, you don't have anything that specifically just targets BCL2. So this had to be completely engineered into the drug Venetoclax to limit the toxicity. Okay, so in CLL, a lymphoid malignancy with near universal overexpression of BCL2, in 2016, it first got approval, Venetoclax, the very specific BCL2 inhibitor for a specific type of CLL, full approval in 2018. and now completely revolutionized the field of CLL. People with CLL, they don't get chemotherapy anymore because of this and other targeted therapies. It's a complete and total game changer. But we're not talking about CLL today. That has never really been our interest or my interest. What about using a BCL2 inhibitor in a myeloid malignancy like AML, acute myeloid leukemia? Well, why would we do that? Because unlike lymphoid malignancies, BCL2 is not universally overexpressed. So why was this even a consideration in AML? The reason for that goes back a little over 10 years ago. And there's a group of colleagues of ours at MD Anderson who first showed that, inhibiting BCL2 could target the leukemia stem cell population, at least preferentially over using something non-specific like chemotherapy like Ara-C shown here. And leukemia stem cells are really elusive, small populations of AML that cause resistance to treatment. Often they don't die to conventional treatments and cause relapse when relapse later occurs. So finding the weaknesses of leukemia stem cells is a really, really important concept or endeavor that people like my colleagues over in the Jordan lab and others have been working on for a long time. So that's what MD Anderson contributed. And then several years later, Craig Jordan, who's now division chief here, he and his group first found that BCL2, first I'll just say that they describe the leukemia stem cell population as the population of cells that reside in this ROS-low environment. So we're not going to talk about that much here. Just know that they basically found a brand new way to identify leukemia stem cells that is arguably better than any previous way. When they looked at these populations of leukemia stem cells and non-leukemia stem cells, they saw BCL2 was really overexpressed in the leukemia stem cell compartment. And then when they did some experiments looking at a BCL2 inhibitor, not one as good as Venetoclax, but when they looked at a BCL2 inhibitor, they found in most cases that you could preferentially target the leukemia stem cell compartment by targeting BCL2. So, in our view here at University of Colorado and working with the Jordan lab, the excitement around targeting BCL2 is that it may be a therapy that can target leukemia stem cells. And we've never had a therapy that could do that before. We haven't even understood what leukemia stem cells are well enough to even have this conversation. But that was the first glimmer that, hey, there may be some weakness inherent in leukemia stem cells that we can exploit with a treatment in a clinical trial. So there were multiple attempts before Venetoclax to try to do this with other drugs. So there were these class of drugs called, or a drug, I should say, called an antisense oligonucleotide, which targeted BCL2. And I've summarized that drug was called Oblimersen. And I've summarized some of the clinical data, but it wasn't all that exciting. And this was done over the course in the early to mid 2000s. Not all that exciting, but also not really clear that it was the best BCL2 inhibitor for a variety of reasons. Then these BH3 mimetics started to be produced. And, like I showed you before, the problem with most of them at the beginning is they didn't just inhibit BCL2, they inhibited all the other family members. So, there was potential for a lot of toxicity. The other problem is they were looking at this mostly in relapsed refractory patients. And it doesn't work that well in that setting. And we kind of know that also today. So not a ton of enthusiasm for this strategy for a long time, but many of us thought that still could be an effective strategy if we had the right drug. So to put you in context of sort of where this was when we were, in the context of the AML drug development, I mean, a lot of this is, I'm trying to entertain, but you can see the timeline down here from the 1970s. This paper from 1973 ushered in the era of induction, and that's horrible, toxic, very aggressive, intensive induction chemotherapy that has become the mainstay for every patient with AML. As a clinician, this is an absolutely horrible thing to do to people. The median age for AML is 68. And people over 60 with AML have about a 20% chance of dying from this treatment. This paper that ushered in this whole era, the age of induction, was based on like less than 20 patients. It wasn't randomized to anything else. It got just grandfathered in because there was nothing else. And all these years, what I call the fallow period, nothing changed. We made no therapeutic clinical progress in the field of AML. Probably a lot of that is because we were hitching our wagon to intensive induction chemotherapy. It was decided arbitrarily that this was the standard of care. And so if anything was going to be added to the field, it was going to have be added to induction chemotherapy. That was sort of like our albatross. And so because this therapy doesn't work very well, none of the add-on therapies work very well. So we got nothing for many, many years. We were very desperate in the AML field for a very long time. Starting in 2009, we didn't know it at the time in the clinic, but things were changing. That's because that's when the first cancer patient had full genome sequencing performed. That cancer patient happened to have AML, and that ushered in this era of incredible understanding about all of the genes that can be mutated in a patient with AML. It was an era of tremendous laboratory progress in getting to the point where AML is probably now one of the best understood human diseases, or certainly cancers, in terms of its molecular underpinnings. That bore fruit. So several years later, we entered this era of abundance when you can see all of these therapies get approved for AML, and a lot of them are targeted therapies, and there's stories behind every one. But I want to give you a sense of where we were when we sort of started developing Venetoclax here. We were, early into the genomic era, well before the era of abundance, still with very, very few treatment options for patients. And that's when we were approached by the company that developed Venetoclax, the very, very specific BCL2 inhibitor. And they asked if we wanted to join up in a multi-institutional early phase first in disease study. And 32 patients were enrolled in this study. And it was us and MD Anderson and Johns Hopkins and Dana-Farber, but we enrolled a very large percentage of the patients and started to have some sense of what this drug could do. This was single agent Venetoclax in the relapsed refractory setting. And here's some of the data. The toxicity profile, I won't take you through too much. There was nothing really interesting about that. But here's the response rate. So, we did have a few complete remissions and some what we call incomplete complete remissions. The overall sort of overall response rate was about 19%. Now, you can think what you want about that number, but we saw in some of these cases pretty dramatic responses. So I'll never forget in the final kind of investigator call that we had, all the investigators in the company, a very prominent clinical investigator in the field, sort of started giving like the eulogy for this drug, saying things like, I'm glad we all tried, and good effort. Let's hope the next one's better. And really saying things that were alarming to me here, because we had always thought that this drug would show its best face in the setting of an untreated, newly diagnosed patient. And these were all relapsed refractory patients. And so the company was sort of being pulled in a couple of different directions. And ultimately they had to decide, are we going to take this forward, or is this it? Is it dead? And they were getting advice from some really prominent people who I now know are big advocates of Venetoclax, saying that they should pull the plug. Ultimately, fortunately for everybody, they decided to move this into the upfront setting and to go after untreated, newly diagnosed patients who were not fit candidates for that intensive induction chemotherapy. And they were going to pair it with a low-dose chemotherapy treatment, either azacitidine, decitabine, or low-dose cytarabine, the thinking there being that those were the sort of standards of care in that population, in these populations. And so you had to give at least the standard of care with the new therapy. So we went into a phase 1/2 study for this population, newly diagnosed, unfit for intensive chemotherapy patients. And each center got to decide, what was the backbone therapy that they were going to give. And we were an azacitidine center. So we gave Venetoclax with azacitidine. And this was a dose-finding study, and of course, looking at preliminary efficacy. So we started to encounter challenges with this study at the site initiation visit. I'll never forget this. So, of course, it's in the protocol, but it doesn't really occur to you until the site initiation visit that there's this bullet point saying that, one of the concerns with this therapy is tumor lysis syndrome, which is something that they were seeing quite a bit of this in lymphoid malignancies. And there was good reason to be concerned about it. This is basically what can happen when a treatment is so potent and active that trillions of leukemia cells or lymphoma cells die at the same time. And while big picture wise, that's a great thing, in the short term, that can cause kidney failure and other problems, even sudden death. And so, that was a known complication in CLL. There was reason to believe that that could happen in AML. For that reason, all patients were going to be admitted and get hydrated, and there was a very specific protocol about lab monitoring. But then they uncovered this caveat that we were supposed to do a formal consultation to our nephrology colleagues as soon as anyone was admitted to start this clinical trial, which those of you who worked in the inpatient side know that the jockeying between services and what's a legitimate consult or not it would make this an extremely challenging ask. And so I was very concerned that this was going to cause this to die in the water because our nephrology colleagues, understandably, weren't going to want to be consulted every time a patient came into the hospital for a potential risk. We ultimately worked past that, but that was a big challenge. The other thing that we knew going into the study was that there was the potential for drug-drug interactions with these CYP3A inhibitors. And so because not enough was known about that, they excluded them. And the problem is that excludes every what we call azole antifungal therapy. And in the AML world, we typically give prophylactic antifungal therapies with these azoles to prevent fungal infections, because that can be a really bad thing in our patient population. So all of us who did the clinical trial, not just here, but at other centers, had to sort of accept that we were going to not permit our patients to get a prophylactic antifungal in order to put them on the study. And it was also a very difficult decision. So the phase 1 study read out with a total of 57 patients. Again, we really aggressively accrued to this study, and there's a lot of reasons for that. One is that we had the sort of hypothesis that this could work really well because of Craig Jordan's data, but also very early on we saw dramatic responses, and so we kind of just cleared the decks for this study and didn't accrue to any competing studies because we were just so excited by what we were seeing. So a lion's share of the patients who in this report on the azacitidine arm were treated here. And so you can see really quickly, this is very early on in this, a lot of the world's expertise in the management of venetoclax, use and management of venetoclax in AML was right here in Colorado. So at the end of the study, there was no maximum tolerated dose that we found. We went all the way up to 1,200 milligrams of venetoclax. 400 milligrams was determined to be the recommended phase 2 dose for a variety of reasons. We really didn't see tumor lysis syndrome because of all the aggressive mitigation that we did. Maybe it's because we called nephrology every time a patient came in. I don't think so, but that may be what they thought. And we saw extremely high response rates, unlike anything that we had ever seen. So just to give you some context, the standard of care is just the azacitidine alone. That's what had been used in a population of patients who couldn't tolerate induction chemotherapy for many, many years prior. And the expectation there is a response rate of somewhere around 30%. And here we were seeing in the two groups, 60%, and then depending on how you, calculated response, maybe even a little bit higher. So we were really, really excited by what we were seeing. When we expanded the study, we basically saw very consistent results. So I just draw your attention because it's kind of confusing. There's so many different cohorts, but in the all-patient cohort, about 145 patients, the CR plus CRI rate was about 70%. So, way more than we would have expected with azacitidine. And again, based on that toxicity profile, we really weren't introducing significantly more toxicity than with azacitidine alone. So we started to also recognize a bunch of important nuances. We saw that, traditional adverse risk factors didn't predict poor responses. So, the community at large, the AML community at large, is still shocked by this, which is hard for me to understand because, all of the risk factors that we have in the world of AML have been defined in the context of things like intensive chemotherapy. Here we have a treatment that works completely differently. So, why the risk factors that predict response or non-response to chemotherapy wouldn't be different than this therapy, it's been hard for me to really understand. But the community has really had a lot of challenges in coming around to this realization that the old rules don't really matter with venetoclax. The things that used to matter, the things that used to scare us about a patient likely lack of response to this to any regimen, they don't apply here. So we really have to change our worldview because of this. We also learned really quickly that I've been telling you how well tolerated this regimen is, and it is. But it is if only after we learned a few tricks. And one of those tricks was that when patients achieve a remission, you need to take a break from treatment to allow for the blood counts to recover. If you don't do that, you can really suppress the patient's bone marrow. So that was an early lesson that we learned and have really tried to get the word out. And then, there was another big question, just like, is this all just clinical trial bias? And that these are all cherry-picked patients, and that's why we're seeing the results that we're seeing. So with my colleague, Amanda Winters, we published a paper looking at this regimen in what we call 3 different ways. So the first way is what we call the ideal world. So these were the 33 patients that we enrolled on the clinical trial with azacitidine plus venetoclax. And these were all, patients that were eligible per the clinical trial. So, this is the cherry-picked population that everybody criticizes, somewhat rightfully. You can see that our reported overall response rate in this 33 patient population was incredible, 90%. But something weird was happening with the AML treatment landscape in general at the same time we were doing this clinical trial. So remember, back in 2016, venetoclax became approved, albeit for CLL. And so by the time we were doing this study, and after getting going and seeing how effective this was, it became apparent that venetoclax could be acquired for patients in the off-label setting. So as many of you know, if a drug is approved for a given indication, it can be prescribed for any indication. The only barriers there are just who's going to pay for it. But because all the excitement over this regimen had been, presented at meetings and things like that, we actually had very little problem getting this paid for in patients that weren't eligible for the clinical trial. So this is what we call the real world. And literally, for much of when the clinical trial was running, we would have patients present to us that weren't eligible for the clinical trial for whatever reason. And we would say, we still can likely get access to this. And it just happened that it was also a 33 patient cohort that we gave off-label venetoclax to. And when I say a real world situation, these were some really sick patients. So there were people in the ICU with multi-organ failure. There were patients with other active malignancies, patients that never would have been candidates for the ideal world situation, the clinical trial. And even in this population, you can see clearly their response rate was not as good as the ideal world, but so much better than what we had come to expect with the alternative, which was azacitidine alone. So even in the real world, we were very, very proud or excited about the responses that we were seeing. And then the third one, this is what we call the fantasy world observation. So some people in the community felt that some of the patients on the clinical trial were not really ineligible for intensive chemotherapy, that they could have gotten intensive chemotherapy. And this is a very subjective call. how do you assess a person's fitness for a very intensive therapy? And so what we did was we took the 33 patients who were treated with venetoclax on the clinical trial, and we put them through this computer algorithm. It's a web-based calculation that lets you basically enter in some baseline data about a patient, and it will spit out what the likelihood of that patient achieving a remission is, and what's the likelihood of that patient dying from the treatment would be. And when we did that and compared this fantasy world, had they all got intensive induction chemotherapy, to what they actually got, what we found was that the venetoclax regimen's response rate was as high as it would have been if they had gotten intensive chemotherapy. But the difference was the death from the regimen was nowhere near what it would have been expected to be had they gotten intensive chemotherapy. So very few patients actually died from this treatment, whereas upwards of 20% of them would have died from the intensive chemotherapy. So that was the fantasy world observation. But this has led to a lot of work that we've been doing, and me personally has been doing, to try to pass along some of these pearls that we've learned from treating so many of these patients. And we think it's really important to get the word out. You need to take breaks between cycles. You need to do a bone marrow biopsy after cycle 1. It's very important to know early on how patients have responded, because this treatment works really fast. So if it's going to work, you're going to know after 1 cycle. You have to mitigate the tumor lysis syndrome. We have to take that seriously, even though it's rare. And then from our perspective, even without antifungal prophylaxis, we had almost no fungal infections, and that's not the same at every institution. Some of my colleagues, and we're analyzing this a little bit more here. For instance, some of my colleagues in other climates like Houston find very high rates of fungal infections. We think that here potentially the dry climate and other situations really made fungal infections in our patients very uncommon. So this is an interesting observation as well. So clinically, you could not, imagine a more satisfying project to be involved in, or a more exciting clinical outcome in a field where there was such great need to be able to help develop a therapy that works so well. Was and is an incredible experience. But we have a lot more to be proud of here about this regimen, and that's the collaboration between the clinical side and the folks in the Jordan lab. So this isn't the time or place to go through in great detail the mechanism, but building on what we learned from Craig's lab all the way back in 2013, we were able to use patient samples, patients who got treated with this regimen, take them back to the lab and work out what we think is a very likely scenario for exactly how this regimen is targeting the leukemia stem cell population. And like I said before, that's a really, really historically hard thing to do. Not enough was understood about leukemia stem cells to even know where to begin. So to have a therapy that is able to target this population, and to show that you can kill a stem cell population in this really, really cool new way, to exploiting this metabolic weakness of the leukemia stem cells, has opened up the field to not only more opportunities with venetoclax, but lots of other opportunities with other strategies as well. So fast forwarding a bit, this is the results just published in the last 6 months of the phase 3 confirmatory study. So the FDA approved venetoclax based on our phase 2 data, not just us, but all the other institutions. But there was an expectation, they basically approved it early, saying you need to be able to confirm this in the setting of a phase 3. We're not going to make all the patients wait until the phase 3 is out, but you need to have a positive phase 3 for us to give you essentially full approval. And we didn't participate in this study, but this was a worldwide company driven clinical trial looking at venetoclax plus azacitidine versus placebo plus azacitidine for a newly diagnosed AML population of patients who are unfit for intensive chemotherapy. And you can see here a couple of things. The response rates are wildly better with the venetoclax. You can see that the azacitidine performs about as I told you, about 30% response rate. And the other thing is that the reliability of this regimen is another thing. So many times phase 2 studies have really high response rates because they were done in like 3 or 4 specialized centers, and then you take it into the more real world setting. And this was, again, a study done on, I think, almost, on 3 continents, in community centers and in academic centers. And to get a response rate that is consistent across all these studies is really kind of rare. And it speaks to the reliability of this regimen. And then here's the survival, and you can see that in addition to being superior with respect to responses, it beat the azacitidine arm with respect to survival as well. So, I can tell you that that's also our data here. These are, this is basically our venetoclax plus azacitidine experience. These are all over 65 versus all other therapies treated here at the University of Colorado over like a 6, 7, 8 year period, I believe. And you can see a very statistically significant improvement in the survival. But back to that phase 3 study, I edited out here the control arm because I just want to call your attention to a couple things from the Kaplan-Meier on the venetoclax arm. So when you stare at this long enough, you start to find a couple of different interesting things. First, you see there is a refractory population. Okay, so, and we know that, right? I told you that the response rate is somewhere around 66%. That's great for the majority of people, but that means 30-ish% of patients are not responding to this therapy. And that's a problem that we'll talk about in a minute. You can also look at the tail of the curve. So this is not, we don't typically in the AML world see a tail on a curve. Usually there's a regression, unfortunately, all the way down to 0 because AML patients typically can't be cured, and they don't, certainly you wouldn't see a plateau this many months out. So I think it's important to also focus on, while there's some people who are refractory, there are also people who are long-term responders to this regimen. And, if you're really truly effectively killing leukemia stem cells, then I think it's not unreasonable to hope that you can cure a patient with a therapy that effectively eradicates the leukemia stem cell population. But I also want to call your attention to this bubble. So the patients in the middle, these are people who probably responded, but then relapsed. And that's the most common scenario for this regimen. So still, we're doing great, high response rates, much better survival than we've been used to, but most people still relapse and die from their AML. So what can we do to improve this? Well, we have a couple of different suggestions here at the University of Colorado. One was to take the same population of older, unfit, newly diagnosed AML patients and to try to guide their therapy to some extent using minimal residual disease, otherwise known as measurable residual disease. So if you have a leukemia stem cell directed therapy, or you're going to try to prove to other people that you do, you better have a way to show that you can get really, really deep remissions. So those two things need to go hand in hand. And so that was incumbent upon us to help to develop the most sophisticated low-level disease detection methods that we could. And at our center, that's been through digital droplet PCR analysis, which is a really, really sensitive way to detect minimal levels of disease that could be left over. And our thinking is that patients who clear that bar of minimal residual disease might be patients that can be maintained on just venetoclax alone. Because in all other scenarios, people are tied to these two therapies. And the azacitidine is a chemotherapy treatment. It's a low-dose chemotherapy treatment, but it still can be tough to take. You have to get a dose every 7 days or every day for 7 days in a row. There's logistics issues there, back and forth to an infusion center. So we wanted to try to free people from the azacitidine, but we know that when people just arbitrarily stop azacitidine because a patient is in a remission, not really knowing the depth of the remission, that it's likely that they're going to relapse. And so this is data we have with our MRD testing that we published in 2018. And what you can see is this is data that Amanda Winters did. These are each a patient, and you can see that down here are genes that she was using to monitor digital droplet PCR evidence of residual disease. And the patients who are in sustained remissions were those who achieved these stars. The star means they achieved full MRD negativity. Patients who couldn't achieve full MRD negativity almost never remained in a remission. And then a lot of these people in the middle who were in a remission but didn't achieve MRD negativity later went on to join this red group. So we know that that's a really important method of determining if a patient has cleared this bar to be able to be maintained on venetoclax alone. The second plan that we have, or the second clinical trial that we have here, and I don't have too much time to get into this, but what may be logical to some of you, but what is in the AML community can sometimes be like a heretical thing, but to say, why don't we, even for younger people or people who can tolerate horrible induction chemotherapy, why don't we stop doing that to them and give them this regimen? Because it's much gentler. You don't spend a month in the hospital. The risk of dying from it is very negligible. It's almost nothing. And very high response rates, and you have a lot of options after you get into a remission. So we have this pilot study looking at younger patients and giving them this treatment instead. So that's something we hope to have more data on in the coming years. But back to one of the problems that we've kind of been coming up against is, I told you that upwards of 30% of people don't respond to this therapy. Well, who are those people? I told you before that looking at the traditional risk factors doesn't give you that answer. So those are important in the setting of intensive chemotherapy. But in the setting of this brand new therapy, how can we predict a responder versus a non-responder? Well, what I can tell you is we looked at 100 different patients from our data set, and none of the traditional stuff told us anything about who was likely to respond. It took a collaboration between my laboratory colleague, Dr. Shanshan Pei, who kind of came to us and said, hey, what's the deal with all these patients not responding to the venetoclax that have these monocytic disease features? And so going back in the history of AML, we used to classify AML based on something called the French-American-British classification system. And this was basically a pathologist looking under a microscope and telling us, hey, these leukemia cells all look alike, and they're M0 versus M2, M4, M5. So there's all these different classification systems. It's really just based on how cells look. Once we start to understand more about the disease biology, no one cared about how cells looked. And so this went by the wayside, this whole categorization system. But Shanshan noticed that there was a unifying feature to so many of these refractory patients, and you could trace it back to how the cells looked under a microscope. Shanshan did it in a much more sophisticated way, but that could be done, that you could say that all the patients that were refractory have similar looking cells. We went on to look at this is just a different way of looking at it, and this is Shanshan's very pretty figure. These are all the FAB categorizations of all the patients at diagnosis, and then this is what happened to the patients who were either refractory or non-refractory. 2/3 of refractory patients, 2/3 of the monocytic patients, the M5 patients, were refractory. When you look at the percentage of patients that didn't have the M5 category, very few of them were refractory. So we really were able to stumble into this really, really cool biological observation to predict a refractory patient to this new regimen. And that has led to a tremendous number of other discoveries from Shanshan and the rest of the lab about how to exploit this. Why are these M5 patients refractory, and how can we overcome that resistance to therapy? So that kind of gets us into the end here. And next steps, I think, from my perspective, we need to understand why some patients don't respond. Those patients from that first blue bubble, who are those refractory patients? How can we identify them? And how can we treat them with something else? they're not going to, they're not going to be successful with the Venetoclax regimen. And like I said, lots of efforts are underway in the lab that are spreading to me in the clinic to help come up with new therapies for these patients. Second step is to look at that plateau and figure out who are those people, the ones that don't relapse, the long-term responders, who are they, and leave them alone. They do so well with Venetoclax azacitidine. Don't mess with them. Don't give them other things. Don't enroll them in other clinical trials. We have a super effective long-term strategy for those patients. And then the most important thing is probably understanding that yellow bubble. So who are these people that get into a remission and then relapse? How can we identify them? I think it's going to be by MRD. If they have residual disease when they're in remission, we know what's going to happen to them if we don't do something. So we need to predict who they are and design clinical trials to introduce new therapies into the mix for those patients to prevent a relapse. Because when Venetoclax patients relapse, their median overall survival is 2.5 months. So there's almost nothing we can do at that point to regain a remission or to keep them alive. So the best thing we can do is to prevent the relapse from happening in the first place. And then I think, the overall effort between us and the lab is these metabolic weaknesses of leukemia stem cells, whether they are leukemia stem cells that are sensitive to Venetoclax or predicted to be resistant to the Venetoclax regimen, or even in the relapse refractory setting, which we haven't even talked about. This is a whole new area, opportunity, way to target leukemia cells and maybe even cancer cells in general. So I think, this is obviously the focus of many people working hard in the Jordan lab. And we're really excited to be able to work with them, learn from what they're doing, and translate it into the lab for our patients. So I guess just to sum up real quick, when I was putting this talk together, I kind of really wanted to convey some things that I've learned from this experience. I think one thing is that when a target has a strong rationale and you believe in it, maybe because you see it starting to work, go all in, and this is what I, want other, people in our group to do, really double down and clear the decks for a treatment like this. It's kind of a rare thing to see in the clinical trial setting, something that can work this well, and really go all in. And I think, that makes for a huge requirement, from a really talented team to be able to rapidly pivot and to scale up and to, sometimes enroll multiple patients a week on a leukemia study. Those are hard things to do, but I think that's really important to do, for the field and for your patients when you recognize, lightning in a bottle, essentially. The second thing, this is a lesson we learned, and it's kind of gone into everything we've done since. The patient samples from the patients being treated, it's different if you're treating lung cancer or colon cancer. Getting access to the disease, to the cancer post-treatment can be difficult or dangerous. For us, it's a routine bone marrow biopsy or even a blood draw because our disease circulates in the blood. So make good use of those samples and don't let them go to waste. And the clinical trial isn't just about adding up who responded and what the toxicities are. The clinical trials also should be trying to prove in vivo if the drug is doing what it's supposed to be doing. So I think that's really important and a lesson that I wanted to convey. And then the third thing is, it's very obvious from this, it's all collaboration. It's collaboration between, the clinical trials team and the clinical team. We have a group of other faculty members and APPs and pharmacists and nurses, and everybody is sort of all in on the same page on these things. And then, of course, for all the reasons I told you, collaborative efforts between clinicians and laboratory investigators, and having a really close relationship where we share ideas and experiences is just so huge. So thanks so much for your attention. I feel like I've been talking forever. Sorry for that. But I would love to take questions if there's time.
Please feel free to unmute yourself, or you can put a question in the chat box and I'll be happy to read it out.
Hi, Dr. Pollyea. Thanks for that talk.
Hey, yeah.
You'd mentioned a couple of next steps, like things you're looking at based on this trial and the results of the trial. Do you have any new studies, anything like that you're working on starting up or are currently open?
Yeah, so we have two efforts, from IIT perspectives. One looking at whether there is a role to safely discontinue the azacitidine. Another one to see whether we can do this for younger patients. So those are ongoing efforts. Then there is now an oral formulation of azacitidine, and so we hope to soon be the first place to offer an all-oral AML therapy, which from just a convenience, quality of life standpoint, I think would be a really big deal and something that we keep hoping to move toward. And then, the other things that are sort of in the hopper are all these strategies that we think may be able to exploit a Venetoclax refractory patient. And so there's a couple of different strategies there. And those are kind of company collaborative efforts that we're working on now with some clinical trial designs and stuff. But I think those could be that's kind of where most of the efforts are right now, from our perspective. A lot of companies and my colleagues have sort of decided that the new backbone is venetoclax azacitidine, and we're going to give everyone that plus drug X. And we're really trying to push back on that because of that survival curve. I think there's people that's not going to work for at all, and then there's people that shouldn't get the drug X. They should just get the venetoclax azacitidine because they do so well. So we're really trying to make that to make it more hopefully acceptable, to try to parse out patients who should get drug X based on likelihood of responding to venetoclax or something like persistence of MRD. That was a long answer. I'm sorry. Too much.
So we have another question in the chat. In the venetoclax resistant tumors, do you see other anti-apoptotic proteins going up?
That is a brilliant question, and really such a terrific question. So yes, we do think that is a contributing factor to disease resistance. Maybe not in the traditional sense that you would think of if this were only a therapy that was working because it was allowing for normal cell death, which is sort of the canonical way to think about a BCL2 inhibitor, and probably the way it's working in CLL. So I think it's a little more subtle and nuanced in AML, but Shanshan published a brilliant paper about why MCL1, which is one of those analogs or partners of BCL2, might be a really important target. So you're right on with that question.
Thank you. Are there any other questions? Well, again, thank you so much, Dr. Pollyea, for presenting. We really appreciate it. And thank you, everyone, for joining.
Thanks for having me. Have a good day, everyone.
Thank
Bye-bye.
you.